Hi, the topic of my talk is WHO glioma classification update in genomics, what every radiologist needs to know. I'm going to start with showing a case over here. A 55-year-old female presenting with word finding difficulty. The initial MRI shows a non-enhancing infiltrative signal abnormality involving the left temporal lobe as well as the left insula. And if I ask my trainees usually what is the differential diagnosis, and that's what they will usually start with, it could be an infarct, infection, encephalitis, and then most of them will respond by saying because it's a non-enhancing tumor, it could be a low-grade neoplasm such as a glioma. However, I want to emphasize that this is what my impression should look like. That I'm thinking that this is a mildly expansile infiltrative, even though non-enhancing tumor. But I do think that this is going to be an aggressive tumor, such as an IDH Wild Type infiltrative glioma. And the reason for that, I'll come back during my lecture why I would write an impression like that. And there is a reason to do that because these are aggressive tumors, and you can see within 2 months follow-up, the tumor is enhancing and it's showing much more aggressive imaging features now. At that time, the tumor was taken out partially, and the integrated histological diagnosis showed that this is a WHO grade 4 glioblastoma IDH wild type, right? So that becomes an important aspect of why we should be dictating these cases in a manner where we have the genomic information also integrated into our reports. So the objectives of my talk, I'm going to talk about some of the important genetic mutations in gliomas, IDH, 1p19q. I'm going to talk about how WHO Glioma Classification Update 2016 should be used in our reports, imaging reports, and how we can incorporate some of this molecular information, for example, IDH, 1p19q, etc., in our radiology reports. So if you look back, the older WHO 2007 classification of CNS tumors divided the gliomas into astrocytic morphology, and these were labeled as either grade 2, grade 3, or grade 4, or oligodendrogliomas, which were graded as grade 2 or 3. And then there was a category which was ambiguous morphology, which the neuropathologist will call as oligoastrocytoma, whether in grade 2 or 3. One of the biggest issues with this kind of histology-based classification system was that there was very high inter-observer variability. No two neuropathologists agreed with each other most of the times. And then also inability of this kind of classification system to predict clinical outcome. And what has happened in the last 10 years or so, with the discovery of IDH mutation, there is a paradigm shift in classification and to some degree also management of these gliomas. One of the earliest papers in Science showed that if you have IDH mutated glioblastoma, there's a much better survival compared to IDH wild type glioblastoma. So even though you have a histological diagnosis is the same, the glioblastoma, but if you have IDH mutation, these patients do much better than IDH wild type patients. The same concept was also shown in another paper in 2009, which showed that this beneficial effect of IDH mutation is not just seen in glioblastomas, but also seen in anaplastic astrocytomas. You have an anaplastic astrocytoma, which is IDH mutated. They're going to do much better than IDH wild type anaplastic astrocytomas. The same paper also showed that these IDH mutations, whether IDH 1 or 2, they occur in majority of the lower grade gliomas. So that's one thing. And this paper also showed that majority of the secondary GBMs, they also have IDH mutation. And only a small percentage, 5% of the primary GBMs have IDH mutation. So majority of the primary GBMs are going to be IDH wild type, the bad tumors, but then there is a small percentage of primary GBMs which are IDH mutated, and they are the ones which are going to do better as far as survival. This is another paper in 2015 in NEJM from the the TCGA group, which looked at lower grade gliomas, grade 2 and 3, and divided these gliomas based on the IDH mutation. So majority will have IDH mutation, and the next thing you look at is 1p19q co-deletion. And a big chunk of these tumors, IDH mutated tumors, also have 1p19q co-deletion, and these were the ones which were classified as molecular oligodendrogliomas. If you have IDH mutation but don't have 1p19q co-deletion, you have ATRX, and these are the ones which are molecular astrocytomas. Another important thing which this paper showed, that almost 20 to 25% of diffuse lower grade gliomas, which are grade 2 or 3, do not have IDH mutation. These are the ones which are IDH wild type, and they are the ones which are going to do poorly. And these are the ones which people have also called them molecular GBMs or pre-GBM. And that's an important differentiation. This paper showed that if you have IDH wild type lower grade glioma, it's going to do much worse than an IDH mutated lower grade glioma. So what is IDH mutation? Isocitrate dehydrogenase. It's basically 5 genes encoding for 3 human IDH catalytic isozymes. Majority will have either IDH1 or 2, but some cases also have IDH3 mutation. Most of the times, you can detect IDH mutation with immunohistochemistry, detects almost 85 to 90% of the cases. However, to have 100% accuracy, you need to have pyrosequencing or next-gen sequencing to really detect the IDH mutation in a tumor tissue. IDH mutation occurs early in glioma genesis, changes the function of enzymes and causing them to produce 2-hydroxyglutarate, a possible oncometabolite, and not to produce NADPH, which kind of protects the cells from some of the aggressive features. Exactly how IDH mutation contributes to oncogenic transformation remains controversial. So based on the IDH mutation, you can divide adult diffuse infiltrative gliomas into the ones which have IDH mutation. And as I said, majority will be IDH1 or IDH2 mutation. And the next thing to look at is if the tumor has 1p19q co-deletion, and these are your molecular oligodendrogliomas. If they don't have 1p19q co-deletion and they have ATRX and TP53, these are your molecular astrocytomas. And more than 50% of adult diffuse gliomas, they don't have IDH mutation. These are called IDH wild type, and they have TERT mutation. And these are the ones which are majority of them are your primary GBMs. I'm not going to talk too much about that, but the next molecular marker you can look at is MGMT. And if these IDH wild type tumors have MGMT methylation, and they do a little bit better than the tumors which don't have MGMT methylation. And as I said, more than 50% of primary GBMs, these are your IDH wild type tumors. And the reason it's important to segregate these tumors based on these genomic markers, because the survival in each group is fairly different. You can see oligodendrogliomas surviving almost 15 years. The median survival for astrocytomas is 7 years. Whereas if you have an IDH wild type glioma, the chances are, the survival is going to be much less compared to the IDH mutated tumors. And if you have MGMT methylated IDH wild type glioma, they do a little bit better than IDH wild type unmethylated gliomas. Another 2 different groups which I'm going to discuss. Again, these are mostly pediatric tumors, but there is some overlap with the adult glioma, so I'm going to discuss that. Is your BRF driven tumors, they have either BRF fusion or V600E mutation, and majority of these are your previously called WHO grade 1 gliomas. And the important aspect is that these tumors usually have very good survival, long-term survival. On the other end of the spectrum, there is another tumor which has been added to the WHO glioma classification update, is your diffuse midline H3K27 mutant gliomas. And these again occur in young children or young adults. And the important aspect of this tumor is that the survival is really poor. And that's the reason, it's important to discuss these tumors along with the adult gliomas. And majority of these tumors, these subcategories, I'm going to show you how these are really clinical syndromes, because majority of them have different age groups, and the presentation is kind of also more specific to the group. This is the paper which WHO published, discussing the 2016 classification update, if somebody wants to go in more detail. But one of the things which came out of this WHO classification update was that now the neuropathologist will have to have 3-layer diagnosis. So rather than a diagnosis just purely based on histology and grade, now we'll have to incorporate the molecular markers. For example, if the tumor is an oligodendroglioma and the grade is grade 2, but the neuropathologist will also have to do IDH mutation status N1P19Q. And if this tumor is IDH mutated N1P19Q co-deleted, the integrated diagnosis should look like this, where you have oligodendroglioma grade 2, IDH mutated, and N1P19Q co-deleted. What is pre-science? And pre-science is the fact of knowing something before it takes place, or for knowledge. And I always believe that, this is really very important for glioma imagers. And two of the things I always tell the trainees to look at before you even look at the image, and I call it pre-image, is the age of the patient. Of course, that's very important. The reason it's very important for some of these glioma subclasses is majority of the young kids, they are going to have either BRF or K27 mutant gliomas. Young adults, majority will have IDH mutated, or some will have K27 mutated diffuse midline gliomas. If you're more than 40 years old, the chances are it's going to be an IDH wild type glioma. So that's important. And then the second thing, which is really important, again, from a glioma molecular subclassification system, is the clinical presentation. As majority of the IDH mutated tumors which are occurring in young adults, they are majority asymptomatic. Whereas BRF tumors, which occur, WHO grade 1 tumors, majority of them occurring in young kids, they usually present with seizures. And majority of the IDH wild type gliomas presenting in older patients, they usually present with subacute neurological deficit. And these are important aspects to keep in mind before you even start looking at the images. For example, this is an MRI of a patient which shows a really ugly ring-enhancing necrotic mass in the right frontal lobe. Perfusion imaging shows the tumor is showing remarkably increased blood volume. The pathology, histopathology, is very classic, showing endothelial hyperplasia, glomerulite formation, and proliferation of the blood vessels. However, the most important thing to me is the age of the patient. This is an older individual. And then the second important thing is, what is the clinical presentation? This patient has been having subacute neurological deficit. As you can see, 1 month history of left side weakness and difficulty speaking before the MRI was obtained. And these two important things, along with imaging and histopathology, of course, confirms that this is a glioblastoma, but more importantly, also confirms the molecular subtyping, as I'm going to discuss. So a few years back, majority of the discussion at our tumor board used to look like this. There is discussion about MRI, imaging, perfusion, histopathology, and then some of the immunostains. But now, majority of the discussion at our tumor boards is kind of centered around this genomic analysis, also known as methylation arrays and methylation analysis and copy number profile, where the neuropathologists are looking at how different genes and genetic pathways are either amplified or suppressed in the tumor tissue. For example, this particular tumor is turned out there was an IDH wild type glioma, GBM, also was MGMT unmethylated. EGFR was amplified, as you can see from the methylation and the copy number profile. And this is really what makes the diagnosis as an IDH wild type glioblastoma grade 4. I consider my GBMs to be good, bad, and mad. And this is what I consider as a bad GBM. And we'll go to the good ones, when we reach the IDH mutated tumors category. So majority of the IDH wild type gliomas, these are TERT mutated GBMs. They occur in older individuals. These are 3 different examples over here. They are necrotic, enhancing masses, usually have poor prognosis, and more importantly, presenting with subacute symptomatic neurological deficit. Another example over here is 43-year-old female left frontal lobe tumor. If you look at the tumor, there is not much of enhancement. There is non-enhancing FLAIR expansile signal abnormality. There is some restricted diffusion in the medial part of the tumor and some increased blood volume also in that medial part of the tumor. However, the tumor looks very innocuous, and it looks almost like a low-grade glioma will be. The patient undergoes all partial resection, and the histopathology comes back as anaplastic astrocytoma, WHO grade 3. But more importantly, this tumor also had IDH wild type genomic markers, so the IDH mutation was absent. And that becomes really an important feature despite the tumor looking non-enhancing and low-grade on imaging. And you can see within 2 months after resection and therapy, there is a recurrence, nodular enhancing recurrence at the margin of the surgical resection cavity, which was resected again. And this time, the histopathology came back as glioblastoma and not just a grade 3 tumor. And you can see this patient doing poorly 11 months after the initial diagnosis and 14 months after the initial diagnosis. The follow-up MRI is showing that the tumor continues to progress and the patient did poorly. Now, this is the category we talked about from that NEJM paper, that these are your lower grade gliomas despite having a grade 3 diagnosis, but these are the tumors which don't have IDH mutation, and these are your tumors which are going to do poorly, also have been called as molecular GBM or pre-GBM by various researchers. And this led to WHO coming up with this C-Impact Now Update 3, which categorized that, if you have a lower grade glioma, for example, an anaplastic astrocytoma, but if this is an IDH wild type tumor by genomic markers, it actually should be labeled as diffuse astrocytic glioma, IDH wild type with molecular features of glioblastoma, WHO grade 4. The important thing is that these are the tumors which are going to do poorly, and they should be treated aggressively and almost treated as a glioblastoma from the get-go, rather than treating them as lower grade glioma. Now, moving on to the IDH mutated gliomas, this is an example over here, a well-defined bifrontal lobe large mass without any significant edema. But the more important thing is that this is a younger patient, 28-year-old male, clinically intact. All this patient has is headaches, so there is no real neurological deficit. And this is, the SWI imaging on this patient showing that this tumor is also partially calcified, as you can confirm with CT scan also. There's partial calcification, and turns out this is an oligodendroglioma, grade 2, IDH mutated. More importantly, 1p19q co-deleted. Hence, this integrated diagnosis of a molecular oligodendroglioma. Now, molecular oligodendrogliomas, as we know, they have median survival of 15 years. This is another patient which was diagnosed with a non-enhancing tumor in the left temporooccipital region in 2011, did not undergo any therapy. The patient was put just on observation, and you can see that the tumor is very slowly, progressively increasing in size. And even in 2018, even though has increased in size, there is no contrast enhancement. And at that time, the patient underwent resection, and the tissue came back as oligodendroglioma grade 2, IDH mutated, and 1p19q co-deleted. So these are tumors which are going to do rather well despite any therapy, despite any chemoradiation. These tumors progress rather slowly and have a longer median survival compared to an IDH wild type glioma. Once these genomic subclassification system kind of became a little bit more clear in the last 7-8 years, we have been looking at some of these some of these morphologic imaging features. For example, we discovered a feature, we started calling it as T2 flare mismatch sign, which was published in Clinical Cancer Research in 2017. And the important aspect of this feature is that these are tumors which are occurring in younger patients, clinically intact. These are very homogeneously bright on T2 and dark. Majority of the tumor is, in fact, hypo-intense or dark signal on the FLAIR images, except the peripheral rim over here, non-enhancing tumors, very low blood volume. But more importantly, what we realized is that these tumors, majority of these turned out to be IDH mutated and 1p19q non-co-deleted. So these are your molecular astrocytomas. So we published this sign, as I said, in Clinical Cancer Research, T2 flare mismatch sign. The important thing was the sign was 100% positive predictive value. It's been validated in multiple studies by different other researchers since then, and is a sign very specific for IDH mutated astrocytomas. However, the sensitivity is rather low. This sign does not, this feature is not seen in all the IDH mutated astrocytomas. It's only seen in 15 to 20% of IDH mutated astrocytomas. So that's an important thing to understand. So just to summarize, IDH mutated gliomas, they occur in younger patients. Majority of the time, the patient is asymptomatic. It's found either, a CT scan done for minor trauma or headaches. Majority of the times, these are non-enhancing or partially enhancing large tumors. They might have cysts also. The prognosis usually is good. And again, another important aspect, majority of IDH mutated gliomas, they occur in the frontal lobe. So that's another important aspect. I've shown you this oligodendroglioma, astrocytoma, the T2 flare mismatch sign. Not all the tumors which have calcification are going to be oligodendrogliomas. We have seen quite a few astrocytomas. So the important thing is that you need to have 1p19q co-deletion status known to really classify them, IDH mutated gliomas, either into oligodendrogliomas or astrocytoma categories. And majority of them are going to be lower grade, grade 2 or grade 3. However, there's a small percentage of higher grade or grade 4 gliomas which are going to be IDH mutated, and we discussed 5% of IDH, 5% of primary GBMs are going to be IDH mutated, and this is an example, and we'll talk a little bit more about that in the next slide over here. So, as I said, the IDH mutated GBM, this is a patient, younger patient, 38, a right frontal lobe tumor, and as you can see, the tumor does show some central necrosis and peripheral enhancement, but also notice that there is a large part of the tumor which is non-enhancing. There is some mild edema, there is mass effect due to the large size of this tumor, and this patient underwent resection, and the histopathology showed that this is a glioblastoma. And the more important aspect is that this patient also had IDH mutation. MGMT was methylated, EGFR was negative, all favorable genomic markers. The patient underwent surgery, temozolomide, radiation therapy, and DC-VAX trial, and this is a follow-up, 9 years after the tumor the patient is doing rather well. There is no recurrence seen, and that's an important aspect to understand. Because these are despite having a diagnosis of a glioblastoma, this is a good glioblastoma to have, and the important thing in this particular patient is that these are your IDH mutated glioblastomas, which are going to do well. So, few facts about IDH1 and 2 mutations. Majority of the lower grade gliomas and only 5% of the GBMs, primary GBMs, have IDH mutation. IDH mutation is seen more commonly in younger patients. IDH mutated tumors tend to be far less aggressive than their IDH wild type grade matched counterparts. T2 flare mismatch sign, if you see that, 100%, almost 100% positive predictive value or specificity for IDH mutated astrocytomas, but the sign is not seen in all of the IDH mutated astrocytomas, only seen in a smaller subgroup of around 15 to 20% of the cases. And again, another important aspect, IDH mutation, mutated tumors, they have a preference for frontal lobe. Majority of the frontal lobe tumors are going to be IDH mutated tumors, especially in younger patients. Now, moving on to another category, which is new in the WHO 2016 classification update, is your diffuse midline gliomas, which classically again occur in younger adults or young children. This is a 14-year-old presented with headaches, and you look at this right thalamic tumor, which is causing some mass effect and even hydrocephalus. However, the tumor does not show any enhancement. There is no edema associated with this tumor, and the imaging features look fairly low grade. This patient underwent a follow-up MRI 2 months later with increasing headaches, and now within 2 months the tumor has increased significantly in size. More importantly, also shows some enhancing areas, and at this time the patient underwent subtotal resection because of the deep location of the tumor. The histopathology comes back as anaplastic astrocytoma, WHO grade 3, and based on this, the patient should be doing relatively well and should have a median survival of at least 7 to 8 years based on the data we know. However, more importantly, this patient, this young child, actually died within a year because of very bad leptomeningeal spread of the tumor. And the important thing to understand why this happened, because this is a tumor which was H3K27 mutant and has been now called as a diffuse midline glioma in the WHO classification update, and it's really an aggressive tumor to have. And just to summarize, H3K27 mutant gliomas, they occur in children or young adults. They are either in midline or paramidline. Classic example is thalamic tumors, or in the brainstem. Quite a few of the DIPG we know, they are now H3K27 mutant gliomas. The patients are usually symptomatic, very poor prognosis. Majority will have some kind of leptomeningeal spread, and the median survival is around 1 year. This is another example over here, an infiltrative tumor in the pons in the brainstem in a younger patient. Turned out this was a K27 mutant glioma, and you can see the patient doing fairly well fairly poorly within less than a year. You can see tumor is recurring, and there is spread as well as leptomeningeal spread of the tumor. You can see enhancing tumor enhancement along the conus medullaris. Within the lower part of the thecal sac over here, you can see the drop metastasis and leptomeningeal spread of the tumor. So these are the ones which are going to do poorly. And as I said, they occur in the midline. We have seen K27 mutant gliomas even in the spinal cord. This is an example, a younger patient who was suspected to have multiple sclerosis based on the paresthesia and then the numbness in the upper extremities, and ended up having this MRI which showed a really ugly looking tumor in the spinal cord, in the cervical spinal cord, which almost looks like a GBM, and turns out this was a GBM on histopathology, but more importantly also was an H3K27 mutant glioma, and was labeled as a diffuse midline glioma. Another example over here is not that common. We've seen a couple of cases of these tumors occurring even in the conus medullaris. This is again a younger adult who had a tumor in the conus medullaris, which was presumed to be a myxopapillary ependymoma, however, turned out to be an H3K27 mutant midline glioma, and a very aggressive tumor to have. And that is why WHO glioma classification update in 2016 categorized these tumors as a separate category, calling them as diffuse midline glioma H3K27 mutant. Why it's important to identify this tumor? Because this is a paper showing how pediatric GBMs correlate with genomic markers as far as their survival. So you can see a smaller subgroup of pediatric GBMs, which are IDH mutated, doing very well compared to the IDH wild type pediatric GBMs. But if you look at the K27, this tumor is actually so aggressive, it's worse than IDH wild type glioblastoma. So it's a category which has been now recognized as a separate category based on this mutation. Now, the last category I'm going to talk about is your WHO. Majority of these are WHO grade 1 tumors occurring in younger patients, young children, usually incidentally found or maybe presenting with seizures. As you can see, 4 different cases, and majority of them either have cyst or cyst with a mural enhancing nodule, and these are the ones we categorize them as WHO grade 1 tumors. Majority of pilocytic astrocytomas and gangliogliomas, they have this BRF mutation, and it's important to identify that because majority of these tumors are going to do really well, and the long-term survival once resected completely is fairly good. However, not all BRF gliomas are lower grade. There are some aggressive BRF driven tumors. For example, this one turned out to be a PXA grade 3. This one was histologically called a GBM, a grade 4 tumor, but was a BRF driven tumor, and that's important segregation. The reason it's important because our neuro-oncologists, despite having a PXA grade 3, but with a BRAF V600E mutation, an aggressive looking tumor after partial resection, did not treat this tumor with standards 2, which is temozolomide and radiation therapy. In fact, once we identify these BRAF mutation, now in any tumor, these patients undergo a targeted anti-BRAF and MEK inhibitor combination therapy, similar to these BRAF tumors in melanoma and lung cancer patients. And this is a 6-week follow-up where you see tremendous response to this kind of targeted therapy. And that's an important aspect. The reason to identify some of these genetic mutations is to have the ability to have some kind of targeted therapy for some of these genomic markers. Okay, just to summarize a few take-home points. WHO classification, glioma classification update 2016 is based on the molecular markers, genomic markers, as we see now that IDH and 1p19q co-deletion status, they provide a better correlation with tumor behavior and biology than was being done by the older traditional histological classification system. IDH mutation is associated with better survival and is seen in younger patients. IDH wild type gliomas, they usually have higher blood volume. I did not really show you an example over here, but that's another important imaging marker we know now. And as I said, these molecular classification, what it has shown us is that these tumors, they're really not, just can be categorized as a broad category of gliomas. These are actually clinical syndromes, and the reason for that is majority of these molecular subclasses, they occur in specific age group and they have specific clinical presentation. For example, IDH mutated gliomas, they occur in younger patients. They're usually asymptomatic, frontal lobe. These tumors are usually large by the time they present, and they have a lot of non-enhancing component. They might have cysts, and as I've shown you, we discovered this T2 flare mismatch sign, which has been validated now with multiple other studies. Once we see that, we know that this is going to be an IDH mutated non-co-deleted tumor or a molecular astrocytoma, not seen in all the molecular astrocytomas, but in a smaller subgroup. Whereas IDH wild type tumors, these are the gliomas which are seen in older individuals presenting with subacute neurological deficit, usually a large necrotic mass with hemorrhage, edema, and high blood volume, and these are the ones which are going to do poorly. Diffuse midline gliomas, the H3K27 mutant gliomas, occurring mostly in younger patients, either young children or young adults. They are midline, paramidline, thalamus, brainstem, spinal cord location, and they usually have poor prognosis associated with leptomeningeal spread. Whereas BRF tumors, these occur in young adults or children, either asymptomatic or presenting with seizures. Cortical location of the tumor, many of these tumors have cyst or a cyst with mural nodule, and that's an important aspect. So I want to thank my collaborators and for as this work you can see is not possible without a team effort, and we have a brain tumor board including some of the eminent neuro-oncologists, radiation oncologists, neurosurgeons, and neuropathologists at NYU. Thank you very much.